I would like to ask Dr. Gertz, thank you so much for that cartoon information on CAR-T. I'm a hepatologist, by the way, not knowing much about this. I have two questions because it's very interesting. Number one, the chimeric T cells that you give it to patients, can those cells undergo cell division and maintain the property of that what you put into the patients? And number two, I know your schematic cartoon is very easy for me to understand, like a 1 cells to 1 plasma cells. But in the reality, would that be benefits to patients if you give more T cells, more than patient myeloma cells, so that it can conquer? Because how do you know about that?
Is he on? Now.
Okay, thank you. So understand that the T cells have been re-engineered to have that engineered antigen receptor on top. That's not incorporated into the DNA in the nucleus. So it can't reproduce a antigen receptor T cell. So you get what you get, and that's what you get for the rest of the time. The second question has to do with dose. And the way most cancer trials are done is, for safety reasons, when it's being researched, you start with a very low dose to be sure that you don't cause harm. And then the dose begins to increase and increase and keeps increasing until you see significant side effects occur. The way it's typically done, it would be significant side effects in 2 out of 6 patients, and then you back down to the 1. So the question of would more cells be effective, I would infer that it would certainly be, but then you'd be facing, I suspect, pretty substantial toxicity risks associated with that. I don't know if anyone else wants to.
No, I think that's a very good explanation. What I would also add on is that those T cells, the CAR T cells, can stay for a few months. It can persist for 6 months, on average, and they can still do the job, what they're supposed to do, but they don't last forever. And as Dr. Gertz mentioned, they won't reproduce. When there is new T cells coming, they will not have any CAR receptor because they are just, not incorporated in the DNA.
Question? No, but we need an online group.
So after the line of therapy or CAR-T, can that be redone? Can a person get a second therapy of CAR-T, or would there be a different line of therapy after that if they came out of remission?
So the answer is, for right now, most patients on the clinic trial have only gotten 1. The relapse patients, though, if they relapse because of what we call T cell exhaustion, meaning that the CAR T cells that were given in disappeared over time and the cancer come back, they could potentially be a candidate to receive more. However, there's an entirely different mechanism of action where the T cells are still there. They're just not able to see and kill off the cancer cells anymore. The cancer cells may dial back the expression of target. So it would be like the CAR T cells swimming around, but not seeing the cancer cells. In this second group of patients, getting more of the same thing probably isn't entirely beneficial. So I think we're still really at the early phase of trying to understand when patients progress or when they don't respond, what's the reason.
Yeah, I agree that we're embryonic in our knowledge. So some people have T cells left behind and some people don't. Some people lose antigen, some people don't. One practical point aside that we've learned from other hematologic cancers, especially lymphoma, is this is expensive. And when it becomes real world, will the payer pick up the tab, even if it scientifically makes sense? And so far, many of them, it's been no, because it's astronomically expensive.
Retail price for current CAR-T therapy just to get the engineered product is $450,000. But if you look at the actual bill of getting the collection done and all the pre-CAR-T testing, any hospitalizations associated with the CAR-T, if you get severe inflammation, there's special medicines that are used to block that inflammation, but it adds to the cost. There's a lot of immune surveillance that occurs. Roughly, I've seen a couple where the costs over 1 year from start to finish is about $2 million. So this business about who is going to pay for that second CAR T is actually a pretty relevant big deal.
On top of that, I also want to add on is you have other non-CAR T therapies like bispecific antibodies, and they are very, very active. So after CAR T relapses, and there are trials already showing the benefit of patients receiving bispecific antibodies after CAR T relapses. So that's going to be an important kind of avenue to look for as well. So not going after one CAR T versus another CAR T, but probably getting those kind of approaches. So that will be important too.
I also wanted to not forget about that antibody drug conjugate, because that would be the treatment that does not require T cell. In theory, that antibody is really carrying the toxin so that the toxin can be delivered and killed specifically at the cancer cell. So while we have all of these tools, how to sequence them best is still being looked at in clinical trial. But I would imagine that even though these strategies still use the same target, right now, mostly it is something called BCMA. Even one failure, one might still respond to the alternative choices. And really the new targets are being looked at. So that should hopefully also improve our ability to treat patients.
We have a few questions related to deletion 17p. And before I ask those, could you just describe, just explain a little bit about why 17p deletion is significant and what it is?
So in all of the cells, there's this particular protein called p53, which is known as a master tumor suppressor. So you need to have it to be able to regulate the cell cycle so the cells don't live too long, don't divide too much, and they die often they need to. If you remove that, then the cells actually misbehave. When it happens within the cancer cells that tend to predict that the cancer cells are going to be the more aggressive type, doesn't really follow the rule. If we think about the wheat story that Dr. Gertz was talking about, it's one of the markers that if you can see a patient's cancer cells, those wheats are probably the tougher wheats to kill. So this is marker of a group of patients that we would like to hopefully be more aggressive at getting them into as great of a response they could have and keep them there. Because we know that once these cells come back, it's just harder to get them back down again.
To make things even more complex, 17, so each chromosome has a pair. So 17p could be deleted at one arm, just one side. It could be deleted on both sides. So the aggressiveness can be different if you have one deletion versus two deletion, and you could have p53 mutation. The p53 is a gene that is present in the 17p. The p is the long arm of chromosome 17, and that could be deleted and also mutated on the other side. So it all depends on what arm is deleted and how many, is there any other kind of mutation as well. On top of that, if there is any other high risk marker like double hit, we call it double hit myeloma, triple hit. So this all is very complicated, when you look at the risks. So this all will determine the aggressiveness of the disease.
Right. The next question is related to that as well, about CRISPR, and maybe you can briefly explain what CRISPR is as well. Could CRISPR gene modification technology be used to correct high-risk anomalies like 17p deletion and some of the translocations common in high-risk myeloma patients?
I'm not aware of any technology that like CRISPR-like technology being used to change the risk status of
If you could,
myeloma.
what is CRISPR?
So CRISPR is a way to edit your gene. There are different mechanisms you can edit your gene, and CRISPR is one of them. It's a very precise way. You can cut out the gene and then edit it. And there is other mechanism like TALEN is one of them. Just to give an example, there's a different technology they use. Meganuclease is one of them. Just edit out, like cut the part of the gene that is you don't want it, and then you kind of just modulate in such a way that the gene works in a different way. So that is, that is one of the mechanism. But what is being done right now is there is a clinical trial in development that is looking at editing out the gene from the allogenic cells, like from somebody donor cells, to edit out some of the genes that you don't want when you give that cells to the patient, like for example, CAR T cells, but you want them to work without giving a lot of side effects. So the CRISPR-Cas technology is being used in that. And actually we have a clinical trial with the allogeneic donor T cells that it made into CAR T cells and then editing out the gene with the CRISPR technology. But I don't think there is any technology to modulate the risk with using the CRISPR.
Once the cancer cells are cancerous, there are a variety of changes within the cancer cells that make them not normal. We know of just very few that carry prognostic implication, right? That tell whether the weeds are aggressive or not. To actually go in there to just chop off those pieces, do not convert the cancer cells and make them becoming normal. So for right now, what we're doing is still mostly using this technology to validate the function of those genes so that we now understand why these features, why this difference in the genes affect the cancer cell behavior. So I think it still is going to be a while before we can actually really easily edit the genes. Also, it's critical that when we are talking about editing the genes, that we realize that your cancer cells live within you, among all of the normal cells that we don't want to mess with. So, I mean, I think technology is there, but it'll take some time.
Okay. We have an online, it starts with a comment and then a question. I like the comment. I said, I heard my first of many of Dr. Gertz's Weeds in the Garden talks, I believe in Los Angeles in 2008. It blew my understanding of myeloma sky high. Today, he did the same with CAR T. Thank you. And my question to all, have you seen any predispositions to serious reactions to the CAR T procedure, perhaps genetics, age, physical health, et cetera?
So reactions, I mean, when you get the CAR T cells, so that could be two parts of that question. One could be you could be reacting while you're getting the cells, and the other one is the side effects that Dr. Gertz mentioned, you know, the CRS, the ICANS, those side effects. So there are a lot of research being done right now to predict what kind of patients are there that could have higher rates of side effects, like both CRS and ICANS. I mean, there is no any specific marker that has been identified as such, especially in myeloma. Of course, patients with a high disease burden, like we talked about, somebody goes in with a lot of disease in the bone marrow or in the blood, and they are definitely at a high risk of those. So we do have some clinical characteristics that will define if these patients are prone to get those side effects, but the research is still ongoing, and in terms of mechanistic understanding, that is still, you know, very early on right now.
Okay. Is CAR T a good option for people with extramedullary disease?
I would say yes. I mean, personally, maybe I'm biased, but I have given how effective it has been in patients who have no options, and having seen that in the clinic, I think because extramedullary disease by itself is a high risk, very high risk marker with the poor prognostic feature, whether they are present at the time of diagnosis or at the time of relapse. And we have seen of all the treatments that we have so far, CAR T is probably the best, in terms of the data, giving them better outcomes. Even if you just look at the recently published paper that looked at the cilta-cel, which is just approved for the myeloma, they looked at the patients with the extramedullary disease. Of course, their outcomes are lower than overall patient population included in the trial, but their outcomes compared to the other products that the patient have received in the other trials, way better than the available products. So given that, I think I would say, CAR T is probably one of the best option we have. Probably bispecific antibodies are also good, but I don't think there is much data out there right now.
Whoops, my phone just went away. There we go. What's your opinion regarding the role of radiation in treatment for myeloma?
I consider radiation still having a role specifically to palliate for pain, or when you actually have a spinal cord compression, when you really need local control very quickly. Myeloma is still quite sensitive to radiation, so it is useful in that way, but it's insufficient on its own to provide systemic control. Myeloma is a systemic problem, therefore treatment needs to get systemically into the bloodstream to wherever the cancer cells are. And this is why radiation and surgery are usually just part of the story, but we still need IV injection, pills, so on.
I think in the community, radiation therapy is grossly overused. I've seen patients who've had pain due to compression fractures, not due to active tumor, not myeloma, but it hurts because the bone's broke, and because it hurts, they get their spine radiated, which for me means less bone marrow for whatever I'm going to use going forward. And I think it's a real problem for people who focus on medical oncology and solid tumors, where lung, colon, breast involves the spine and radiation is required because the systemic therapy is not as good. And I think there is a lot, not in academic centers where there's a lot of experience, but I see patients get radiation to their entire spine, which I personally felt was completely inappropriate because it was being done for pain, but the pain wasn't due to cancer. The pain was broken bones. And that's a big difference.
That's yeah. Anybody else?
Yeah, absolutely agree.
How do you determine what's best, a second transplant or a CAR T?
So right now, if you ask me, we don't have data comparing second transplant or even first transplant versus CAR T. Second transplant is done in two settings. One, if the patients have received the best response to the first transplant, and then you could consider second transplant as an option because we have shown that that could be beneficial. It's still very safe. You know, the risk of the mortality is very, very low compared to CAR T, if you will. But there is a trial which has been ongoing, comparing, looking at the CAR T in the second line, third line, and that will show the benefit of the CAR T, but there is no head-to-head comparison. So I think it all depends on what is available to the patient, and whether the patient has derived the benefit from the first transplant. And if the benefit is more than 2 years of maintenance, then probably I definitely discuss that option with the patient.
That bears emphasis. I mean, if you got a
Mike,
transplant, you got a transplant and you relapsed a year later, second transplant wouldn't be very appealing to me. You get a transplant and you relapse 8 years later, and I'd be asking myself, well, why would I bother with CAR T? And so that's not just what do you do, that has to be individualized for the patient's prior response, as you mentioned.
Yeah.
I was going to say the only other thing that factors in is if I have that discussion with a patient and they remember how hellacious it was even 8 years ago, then you don't do it again. So, I mean, there's a large part of what you think, you know.
Remember, many of these patients were actually, some of them a decade out from their last transplant. We are never younger, and body reserve go down in time. So second transplant is really for those very specific cases where the first transplant went well, patient was quite young, and really the stamina has not declined so much. Luckily, you might not need to pick one or another. You might think about them as all available choices, because you can choose one and still have the second choice down the road. Patients who get salvage second autologous transplant, should they relapse, the CAR T hopefully will still be an option then.
We've transplanted 60 patients over the age of 75. I don't know what the other experience is, but we're not that timid about age. No, you don't transplant over 75?
No, we do.
We do, yeah. The oldest patient I have transplanted is 79, and he did very well because he was very healthy and fit.
The oldest we've done is 78, and I think you're showing off.
No.
We recently, was it in Houston? We recently had a meeting where one doctor transplanted somebody who was 85.
No.
Wow.
Yeah.
It was Mel 60 or something.
No, I did Mel 140 for 79. He's 3 years out and doing fine.
Great. Let me see. Oh, wait, where did I put? Is there a risk? And although this is related to CAR T, I'd like to expand it to ADCs and bispecifics. Is there a risk for secondary cancers on CAR T, as with other cancers?
Yes, there is a theoretical risk, because the CAR T cells are made in a way that the gene is, the vector is inserting a gene. So there is a risk of second cancers. That's why FDA is mandating the follow-up of these patients. Anybody who got this genetically engineered cell therapy, will follow it up for up to 15 years for the second cancer. So that is kind of a long-term follow-up. So we don't know much data because they are evolving. Look at if you look at in myeloma, the pivotal study data, for example, the cilta-cel, the CAR-T data follow-up, and did show the increased risk of second cancers. But it is difficult to tease out because these patients have received so many treatments. In myeloma, patients have an inherent risk of second cancers by itself, biologically maybe. So we don't know whether that is because of that risk versus the CAR-T adding the risks. So follow-up, longer follow-up of these patients on trial and now off trial will be able to get more idea on that one. But definitely there is a theoretical risk and we need to follow these patients longer.
I was going to say, I think as we learn more about this field, the way those cells are made will make a big difference. Of thousands of virally transduced T cell products, I don't think there's any cases of a T cell leukemia, but there are recent cases in some of these newer methods of gene editing that we think are very precise, CRISPR you mentioned, but they're not as precise as we think they are, and there's cases of T cell leukemia. So there's a lot of nuance. I think as we tinker with these cells more, we may see more of these problems.
Yeah, so there's certainly an attempt to sort of insert what we call suicide gene into this product so that if they misbehave in the patient's body, we can turn on that suicide genes and kill off this T cells that have just been given. So sort of just providing a safety net. So I think first, you think about it in this way, the first car ever made going out in the road isn't going to be the best car that you could have. But that's really the first car that has to go out because it'll be important for it to be available for people who need it. But there's so much that's happening to make the product more efficacious, to make it safer. There was a question earlier that was talking about, well, why not just give more so that there's so many T cells that can actually all fight to bind onto the cancer cells? Well, the other way to think about it though is how about if you actually engineer the T cells that have that can bind onto more than one target on the cancer cells, so that rather than relying on one, maybe it can see two different spots on the cancer cell. And it just might be able to recognize the cancer cells better, just in case the cancer cell is try to shut down the production of that marker, you still have the other one. So there are all kinds of technologies that are happening. So hopefully, maybe in the next few years, we won't really be beating ourselves up for who to get it, when to get it, is it going to be repeated or not? Maybe we just have better product all around.
Mm-hmm. Yeah, no, I agree. I think with time, the technology is going to get safer and safer and better. It is most of the cases. I always tell my patient that Wright brothers flew the first plane, but we're not flying the plane. It's a different plane now. So that's going to happen with the CAR-T technology as well. We are already seeing that in the clinical trials, right? With the newer binding technologies and synthetic binding domains, we're seeing that better responses, safer CAR-T. So I think that's will happen.
Okay. And we have questions, obviously coming from all sorts of directions. Here's one in a completely different direction from where we've been. What's the best course of action that I should take during the smoldering myeloma stage? My oncologist is currently doing blood tests every 3 months to monitor my test results. Should I be doing more other than taking calcium, vitamin D, and exercise?
I think that's a good oncologist. That certainly sounds right to me. I mean, I think that's reasonable as long as there's no indication of the numbers changing that you'd want it more frequently. I mean, it's kind of arbitrary, but every 3 months is kind of what I do in my practice, actually. And calcium, vitamin D, and exercise sounds right.
Yeah, no, I agree. I mean, we had a clinical trial for high-risk smoldering myeloma, and we kind of discussed that trial with them. But that trial is no more. Right now, it's all enrolled. So right now, we just do the standard of care of monitoring and just regular visits with us. Okay.
I realize though that from patient standpoint, isn't it weird that we're telling patients that they should just sit on their cancer and not do anything? When I compare myself to my breast oncology colleague, they'll just recommend treatment to aim for the cure as early as they know that there are cancer cells there. I think the caveat is that not all smoldering patients will progress, and to overtreat cause long-term side effects. And this is exactly why, unless we know that what we do today will have a long-term benefit, sometimes not doing anything, but just watch that unique patient in front of us closely is the best way to go about.
Here's checkpoint inhibitors have been very successful in solid tumors and other cancers, but have not in myeloma. Could you explain, first of all, briefly what a checkpoint inhibitor is and why is it having so many problems in myeloma and what is the status?
So, so checkpoint inhibition is like the T cells that Dr. Gerd just mentioned, how fascinating it is to fight the cancer cells. But unfortunately, the body has intrinsic mechanism for their own safety, but using cancer is capitalizing that mechanism to put the brakes on the T cells. So basically, the T cells are kind of important. They are there, but they cannot fight because they are putting the brake by the mechanism of the checkpoints. And there are different checkpoints. One is called PD-1, PD-L1, which is the one most, it's kind of sought after target. But at the same time, there are other checkpoints that we are discovering like LAG3, TIM3, TIGIT, and all those stuff. So they are basically the mechanism of pathways that the cancer induce so that you put in the brakes in the T cells. And as you said, I mean, checkpoint has been a kind of a revolution, and that is the revolutionary kind of a treatment that we had for other cancers, in particular melanoma and lung cancers and other solid cancers, but unfortunately not in myeloma. So what they did in myeloma is that when they use a checkpoint, the PD-1 blocker, especially as a single agent, there is no activity. So if in cancer like myeloma, we have seen if there is no single agent activity, it is difficult to survive. But we did a trial looking at a combination with the immunomodulators like IMiD, like pomalidomide and lenalidomide. What happened? They had some activity, but unfortunately at the cost of the side effects. So a lot of people died because of the excessive activation in the immune system. So checkpoints, I would say probably still has a role because myeloma is a kind of dependent on the microenvironment for survival, and they create the microenvironment, the kind of soil around them very favorable for them. And so they create all these pathways so that the T cells become important, but that there is no kind of a specific checkpoint that is safe and that is kind of active in myeloma that we know of. But there are trials. Right now, there is a trial against TIGIT, which is one of the checkpoint, and actually that is open at our place. We'll see how that pan out. It's in combination with another checkpoint, not with the combination, the IMiD, because now there is because of that high risk of side effects, people are not doing with IMiD as a combination. Maybe we need better partner. Maybe we need better checkpoints. Maybe it could be a rate limiting step, because all immunotherapy has to go through the pathway. And if that pathway is blocked by the cancer being more active and producing those checkpoints, you may not see the full effect of the immunotherapy. So you might combine the bispecific antibodies. You might combine with the CAR T, who knows? So those kind of things, theoretical advantages of their using the checkpoint blocker.
Okay. It's kind of an odd question because it's more logistical. It's not, but I'm curious to me. I'm about to start treatment and was told that harvesting and holding stem cells for deferred stem cell transplant is not possible right now due to a shortage of storage supplies, and that's my only option. My only option is to harvest and proceed to stem cell transplant. Is this a nationwide issue or just something specific to my Pacific Northwest Cancer Center?
It's not a nationwide issue.
Okay.
I think sometimes places run out of space because we use about 10% of the second transplant cells, and in which case this place needs most likely.
Okay.
That's why I'm not so clear how interested I am in harvesting and letting this stuff sit, knowing what I know about when they go. And I think there will be data coming out very, very shortly to indicate that that would be a therapeutic error. And so the whole concept of why are you harvesting for storage? I mean, you're all recommending early transplant for eligible patients. So strategically, it sounds wrong.
Okay. I hope that was helpful.
I will add one more.
Okay.
I agree. I totally agree with. But what we have seen after the CAR T patients or all these like new immunotherapy patients, especially for the CAR-T, we have seen cytopenia, low blood counts as one of the side effects. And fortunately, we have been able to salvage their blood counts using the stem cell. If we had not collected enough stem cell at the first transplant, we probably won't be able to do that. So it could be used down the road, may not be for the second transplant, but for the, for all these new therapies coming in the pipeline. But I agree. I think most of the time we have actually shown that, and multiple groups have shown that the use is pretty low. And of course, the cost to store that is pretty high for the center. So it's a kind of a,
And we should also say that Medicare will not pay for this for a
That's
very good
right.
reason, because they
Yeah.
don't get used. Those cells don't
Right.
get used. So-
And the thing is, I think sometimes in patients' mind, it's sort of like, well, I'm just going to put money in the bank and I'll just deal with it later. I think in reality, though, you do get catheter placed a large size under the collarbone for the purpose of collection, and usually we'll leave it in so that when patient comes in for their admission to get the melphalan, to get the cells back, it is used for that purpose as well. And then it's pulled out whenever you don't need it when you go home. To split this out is really adding not only additional cost, but also additional complication. You got to pull this thing out after you're done with the collection. Then whenever you come back for the transplant, well, you get another catheter, because otherwise, how are you going to get all of the blood transfusion, IV fluid, antibiotics, and so on, and daily blood draw with just a little IV access? So I think sometimes it seems so easy to say, well, I'm just going to collect and worry about it later. I don't know that that's true. Also, I think there's a prime time why we say you do the collection when someone achieves maximum response, and that's usually after 4 or 5 cycles of treatment, because the myeloma-related symptoms have improved, you're in remission, but also you're not too beaten up from that induction chemotherapy. So hopefully you're in an excellent shape to be able to get through transplant, recover from it, and this transplant's done and over with. Oftentimes when patients collect cells and not use it, they actually go back to get more chemotherapy to sort of sustain that remission. And then when they think about transplant, it may actually be when they relapse. They may actually have some treatment-related toxicity that makes them actually not as good as candidate later, comparing to that 4 or 5 months after induction. So I say if you're committed to transplant, the only time I would collect and store would be issues with social support, would be say you don't have anyone to help with at home and you need time to sort that out. And the reason why the collection is done is mostly just so that we at least have already had the product before patients get too many treatments, because then we're not going to be able to get that really good yield. Remember, when you use weed killers, your normal plants are not happy. And if you use them for too long, you might not be able to get those seeds, those healthy seeds that are going to be important to give back in.
COVID question. Does Evoshield work for COVID protection for patients on daratumumab?
It should work. I don't think there is any, that could
Direct
not,
antiviral?
Not an
it's a
issue.
direct antiviral, so there is no interaction and no
Okay.
mechanism that could.
And
Absolutely. I mean, you think about it as this. This is already pre-made antibody against COVID. So in case you're already vaccinated, but you're on treatment that would partially inhibit your ability to respond to the vaccine, think about it as money in the bank. If you don't make enough on your own, that Evoshield is sort of top it off. So hopefully you have enough just to really fend for in case you come across the infection and hopefully not get into serious complication. So I recommend it, in fact, in patients who are on immune suppressive therapy.
I'm just curious, we now have 2.5 years of experience with COVID. How should myeloma patients think about COVID today? Is it different than it was when we started this?
I like to think so. Now I'll tell you, just because I was an always no doctor at the beginning. 2 years ago, patients with myeloma come in, they want to get together with their family. I'm like, no, please don't do it. Wait. Now, 2.5 years later, there's some events in life you cannot always wait. So I actually usually say, do it with precaution, but also be sure that you're protected. And people in your circle ought to actually be to protect you, taking good care of themselves. So vaccination is key because it's the only thing that we know to be truly preventive. This Evoshield is a new tool. It just tops it off, but it's not replacing the vaccine. And I mean, I think ultimately also having ability to get in for treatment quickly if there is such an infection would also be another key thing. People who need to worry about getting infection and get into serious complications are going to be those who are very, very soon post-CAR T or transplant. Those are people that I do not want them taking risk. And probably folks who have kidney failure, folks who have existing cardiopulmonary problems, because their body reserve is so low, they can get into trouble quickly.
Pritesh, you have any?
No,
How's COVID affected your clinic, and has it changed recently?
yeah, look, obviously there's a lot that's different from 2 years ago, right? Because if you remember, if we think back to the fact that we had no testing, we had no PCR testing, we had no at-home testing, we really had no treatments, we had no oral antivirals. And so the world is different in many ways. I think that we can't forget that vaccine response in this very immune suppressive disease is not as good as the general population. Vaccine response in especially CD38 monoclonals is not very good, even if you get it subsequently, even if you get it months later. I think if you're alluding to whether we see folks in clinic, I think we all do now. I think we're doing probably more of a disservice to people by not seeing them and not giving good therapies. So I think most of us have moved away from that, but there is there's definitely some utility to, hey, look, we are able to do televisits that we weren't able to do as long as you go somewhere else and get your therapy. So I think we've learned a lot, but there's still, I think, definitely reasons to be very cautious around folks who are especially getting those drugs that I mentioned.
Do you do a lot of telehealth consultations these days? All of you?
You still do, not much, not like what we used to do in 2020, but we still do for some patients. And that is actually good for some patients who were not on very active treatment. The disease is just in good control and they are on maintenance and they live far off, like, 3-4 hours from us. I think just to have telehealth visit is good for the patient. So, but not much at what we used to do.
It's still a third of my practice. We actually send kits out so that the blood tests are done in-house because I can't stand going through Epic documents. And so we have our labs and we have a face-to-face, and it's still a substantial part of my second opinion and ongoing monitoring. It'll vary because there's state laws.
Yeah, that is the main challenge. So we are doing that, and I was actually in favor of doing, especially for patients out of state, but there are some state laws that would preclude. So they unfortunately have to come to see us.
Okay. So it's just be vigilant, right?
Yeah.
Now I'll come over there, yes.
I just wonder if any of you have patients who are MRD negative, but still have a bit of an M spike. And what would you think that one's more accurate, or what's going on?
The person who best answered this is Dr. Gertz, because he was telling us about this new technology that's really very sensitive at identifying the abnormal protein.
It depends. If it's at day 100, you don't know what the M spike means. You just don't have a clue, because even though they say that the M spike goes away with a half-life of 3 weeks, I know that's not true, because we're now seeing patients who are 6 months since they got their last daratumumab and they still have daratumumab in the blood. No doubt about it. However, if you're out farther beyond 6 months, I believe the M spike more than I believe the MRD, because there are technical reasons. When you collect cells in the bone marrow, the first teaspoon might go for the clinical count, and the second teaspoon for the fish, and the third maybe for proliferative index, and then maybe the fourth teaspoon, whatever's left over, goes for your MRD. And sometimes those are dilute and they're technically unsound, and the MRD is not so reliable. So there's a lot of technical stuff about that makes it imperfect. And if I see someone by formal criteria, the way we have all agreed, if someone is MRD negative in the marrow and there's a small M spike visible, the highest level of response is very good partial response. That patient's not a CR, not a stringent CR, and the MRD negative doesn't change that response by consensus. I don't know what's right.
No, I think that's exactly right. And the other thing we have to understand is myeloma in a bone marrow, when you pull, it's a patchy disease. So when whatever area that somebody is doing a marrow goes through, may not be able to get the good sample. So that is completely blind procedure. So you may not be able to capture that. So that's what we talked about circulating blood assay as a, probably they might represent the tumor burden better than the just 1 point MRD. And also imaging, relying on the imaging is the key. So I think I agree. I think the farther down the road, especially if you are not on any treatment that could interfere with this M protein interpretation, those protein could be especially detected by newer, like a mass fix, and those technology would be more valuable.
I have heard that there's a second study going on for CAR T cell. Are you expecting any major differences from the one that's just been approved? And if so, what are they?
Second product that you talk.
A second research study for CAR T cell.
So there are the CAR T cells right now. There are 2 approved products, and those products are now being investigated in the early lines. So the patients, so right now the CAR T is approved for patients who have no options at the 5th line. But we just completed a trial where we used that against the standard of care therapy at 1 to 3 prior lines. So a little bit less heavily treated than what this product is approved for. There's a trial that we're opening soon in newly diagnosed myeloma patients. So newly diagnosed myeloma patients in general, they go to VRD or DARA VRD induction, and they go to either transplant, or if they're transplant ineligible, go to like maintenance. Now there is a trial where we're randomizing CAR T versus standard of care. And there is a CAR T versus transplant study also coming up. So they are definitely moving in the front lines, and we have to see the value and the efficacy of that product or the treatment against the standard of care, whether that is going to be, it will take some time.
Question over here.
What about CAR T causes persistent cytopenia? What's the cause of it?
So it could be multiple reasons. One, of course, the CAR T, before the CAR T is given to create a kind of a favorable environment for our body, you give a chemotherapy called lymphoid depleting chemotherapy. It is not very suppressive like when you go for transplant, we give melphalan, which is a very high dose, can make your marrow completely empty, and you need the stem cell kind of a rescue for that. But still, it does, especially if you are already been heavily treated with multiple lines of treatment and different class of drugs like alkylating class of drugs, and they're already making the marrow weak. Having that treatment after that can make the marrow even weaker, and so it might be difficult for your for your body cells to regenerate nicely and get your blood counts normal. So the cytopenias, especially we know in lymphoma that it could be a problem. In the myeloma and commercially treated patients, I can tell you that there definitely is a concern. But people do recover. People do recover. You just have to make sure that you support them doing that. I have seen patients recovering after even 2.5, 3 months. I was thinking of giving stem cell boost and patient recover. But during the first 3 months is very crucial to support them with growth factor support, with blood support, and make sure they are in good prophylactic antibiotics so that they don't get like bad infections.
Okay. Go ahead.
I was going to say they may also be an effect of this inflammatory response. So T cells getting super excited release these soluble factors, we call them cytokines. And we know from many other settings, they have an effect on those seeds, right? So it could also be nothing. I'm sure it's multiple things here, but it could also be the inflammatory response plays a role.
Final unfair question, and I don't want you really to spend a lot of time, maybe just one example, but this is a great way, I think, to close it. Submit what treatments are on the horizon in 5 to 10 years that were not mentioned today? I recently read an interview with a myeloma doc, or with a Mayo Arizona doc, on a web article that treatments 10 years from now will look very different from today. So what's one thing each of you sees that's very different next 5 to 10 years?
I like to think that with all of these many tools that are coming about, the thing that bothers me the most is I actually don't know for each and every patient in front of me what their own cancer cells would actually be sensitive to. So if it's a wish list for me, I like to think that our ability to understand patients' unique genetic makeup of their cancer cells and also those microenvironment cells, the cells that are in the niche, that are in the soil of that patient. And also another part of it is really how their own genetic makeup would make them react to medicine, would together get calculated into a signature that help me choose the right treatment for them. I don't know that right now there's so many things that are getting developed. Myeloma is rare. You cannot test 100 different treatments at the same time. So I think we need to be able to say what we have today, in whom, in what sequence. I think that would really be helpful.
I'm grabbing it before. In our world, unfortunately, we don't have these targeted therapies. So I think we're going to see expansion of more immunotherapies. And so Dr. DeCarl said we're moving them earlier on in the treatment paradigm, and they're going to get better because there's a lot of tinkering that can be done. There's different immune cells that can be used. Doesn't have to always be T cells. So I think we're going to see an explosion of newer immunotherapies, and also hopefully ones that are off the shelf and we don't have to wait 20, 30 days, or even ones that are manufactured really quickly. So there's lymphoma products that are being manufactured in a 48-hour time period. So I think this is where we're going to see major advances in the explosion. It's really continuing the same vein of the discussion this afternoon.
I don't want to see dexamethasone in the treatment anymore.
No, I agree. I think immunotherapy is the kind of center stage in myeloma. It's already, we are seeing that, and combining immunotherapy, because even last year we saw combining daratumumab with the bispecific antibody talquetamab, the response rate are much higher, even in dara refractory patients compared to just single agent talquetamab. So that is already moving towards combining this immunotherapy, targeting the tumor and targeting the microenvironment. I think we're moving to that, and hopefully will be, if not cure, probably providing a long-term control of this disease for a large proportion of the patients.
Iberdomide and bites will kill CAR-T. That's what I think.
I wish you had a strong opinion about things. I want to thank you all. We really have to close at 3. So I want to thank you all. And before I thank you, I want to thank our faculty. And I want to turn this over for final word to Jenny. Thank you.
Oh, I just want a second round of applause for these amazing doctors. It's really obvious that you can see how you need a myeloma specialist on your team with all these nuances. So I just thank you for watching online. Thank you for coming in person. And just thank you so much for supporting. Have a great time home.